It's just slightly after 2 o'clock, and so again, welcome everybody, and nice to see many of you coming back again. Danny, that reminds me, let's make sure we figure out if anyone wants a certificate for completion of the, having been with us for multiple sessions. We can reach out to Joanna. We will, and we're happy to send something to you that just acknowledges your participation in the summer school program. Also just before I introduce Manraj, just to say, so we'll, feedback is really helpful. And so again, if you're in contact with us in any way, and I hate it, but negative feedback is also very helpful, I guess is what I would say. And not that there won't be any negative feedback about Manraj's talk, but I mean, not negative, but constructive, suggestions, anything you like, because anything you want to share is really helpful to us. We'll be moving from this summer, the summer school program will move into a monthly, our approved team meets more regularly, but we will be also launching a monthly seminar through the academic year, so September through to the spring. So suggestions for topics that you'd like to see covered, you'd like to hear more about. I'm hoping that many of you, all of you, will continue to join us throughout the year whenever you can. So again, we really welcome your suggestions in that regard. So I would very pleased to say that today Manraj Kaur is joining us today, and Manraj is a superstar postdoctoral fellow at the PROMs Center. Manraj completed her PhD at McMaster with Ann Claassen and the group there, and her focus has been around patient-reported outcome measures and also cost effectiveness, and particularly about utility measurement. And so I think, to me, this is it's an extremely important area in terms of thinking about how we channel patient perspectives into decisions about healthcare costs and how we spend our healthcare dollars. And for those of you who are joining us from countries outside the US, some of this will make even more sense in that countries, say Canada or much of Europe, with national healthcare systems, the payers are effectively the taxpayers. And so that's essentially how, and I'm going to leave it to Manraj to explain some more detail, but utility measurement is one way that we can use the perspective of the population to help understand where the priorities should be in healthcare spending, but tying that also to the endpoints of quality of life. And so so I think it's very timely in terms of as we explore healthcare spending overall, in terms of understanding where when we need to cut back or we need to spend differently, to put healthcare dollars where it matters most to patients, where we have the biggest impact, makes a whole lot of sense. And so that's really the crux of utility measurement. But it is important to recognize also that utility measurement is distinct from, we've been talking about PROMs, and a PROM is not a utility measure. And again, I'll leave it to Manraj to explain more of it, but effectively, utility measurement was developed through by the health economists. And if you think about with PROMs, as we talked earlier in the summer, PROMs came to us from a lot of the social science. So it came from psychology a lot. And then essentially, so there was, if you think of where all this came from, so PROMs came from psychology, and with it, that's where the psychometrics of the early PROMs came from. And then from a psychometric perspective, then education psychometrics hit PROMs, the PROM psychometrics, so we had classic test theory, and then we sort of touched on, then we were touched by what had been learned in education, and that's where we got a lot of the modern measurement theory. And then, so that sort of came in this side, but then on utility measurement came from a separate school, which was really the health economists. And so I think Manraj will explain that even better, but I think just to give you sort of a framework for how utility measurement is actually very different from patient-reported outcome measure. And yet people will use in the same sentence an EQ5D and a PROMIS 29, like thinking that they are the same thing. So I'm pleased that you're all here to gain this depth of knowledge about the differences between utility measurement and PROMs. And I will leave it to Manraj to further enlighten us.
Thank you, Dr. Pusek. And thank you everyone for joining us today. Special thanks to PROMs Center for the invitation. And as the title suggests, today we'll be reviewing the role of PROMs in cost effectiveness evaluation of health interventions or programs. So I always find it helpful to start with the why. Why am I here today? Well, Dr. Pusik already introduced me, but briefly, like I'm a postdoctoral fellow at PROMs Center. And as a postdoctoral fellow, I'm interested in many, many things. But I'm most interested in learning how to develop rigorous PROMs for use in cost effectiveness evaluation of health interventions. I developed a new preference-based measure for use in economic analysis of breast cancer interventions during my doctoral program. Don't worry if you've never heard the word or the term preference-based measure before. Hopefully it'll become clear as we go along. At the end of the session, I will introduce the development methods that we used for developing the breast-specific preference-based measure. However, the agenda for today. So what I hope to achieve is provide you with an overview of what is cost effectiveness analysis, introduce the concept of health utility and its measurement, but most importantly, highlight how PROMs used in economic evaluations differ from PROMs that are used in clinical effectiveness studies. So now let's ask, why are you here? So you're either a healthcare provider, a consumer, or you pay for healthcare and play however big role in optimizing health system performance as defined by the Triple Aim framework, which has been used by many organizations. According to Triple Aim framework, new interventions or programs must be developed simultaneously to pursue all three dimensions as shown in the diagram here. So they must improve patients' experience of care, they must improve population health, and they at the same time reducing per capita cost. In the Proof Summer School series, we have heard from internationally recognized experts and scientists on how well-designed rigorous PROMs can play a vital role in all of these areas. PROMs are used to monitor health status and change in health status. They're used to enhance patient-clinician interaction so as to inform patient-centered care. They're also used to evaluate quality and performance of health systems or organizations. Today, what we'll see is how PROMs are used to inform resource allocation decisions. So when a decision maker is faced with choosing what intervention or program to fund, they cannot exclusively focus on cost because you run the risk of choosing an intervention that may be less effective. And similarly, focusing exclusively on effectiveness outcomes may result in interventions that are costly or, in a nutshell, do not offer the biggest bang for buck. So the field of health economics has evolved over many, many years to devise ways in which the cost and the effectiveness component could be integrated. And the result is what we know as cost effectiveness analyses. In cost effectiveness analysis, we estimate cost per unit of effect. So essentially what we're doing here is we're comparing two or more interventions on the basis of their clinical effectiveness. We are identifying the cost associated with each of these interventions and then assessing if the intervention was worth it. The common misconception around cost effectiveness that you may have heard is that its purpose is to save money. And this is not correct. Because the cheapest or the best way to save money is to do nothing and let an individual die. Because if they're dead, they don't cost money. Keeping people alive causes investigation or costs money. So our goal when conducting cost effectiveness analysis, again, another common misconception is not to save money, but to spend the money that we have in a way that allows people to live their longest, best possible life. So I introduced the concept of unit of effect here. Let's see what that means. So if you're comparing, let's say, ultrasound guided biopsy, for example, your unit of effect may be number of cancers detected. In bariatric surgery, you may be more interested in number of patients who have successfully achieved remission of their diabetes or control their cholesterol levels and so on. It could also be days spent in the hospital, death avoided, life saved, or life years gained. The problem with these sort of effects, or so-called natural units in cost effectiveness world, is that while they're easy to measure and easy to understand, they do not compare across different populations. So what I mean by that is that when you use natural units in cost effectiveness analyses, there's no means to compare life gained by a 10-year-old versus life years gained by a 35-year-old or a 70-year-old. Further, you cannot compare between diseases. So life years gained by an intervention managing prostate cancer is that same as life years gained by an intervention managing breast cancer, and so on for specialties. Most importantly, they do not include the range of outcomes that matter to patients. So to navigate this problem, the world of health economics has come up with a concept known as quality adjusted life years, or QALYs for short. QALY is a single number or a single metric that combines quality of life and quantity of life. Quantity of life is expressed in survival or life expectancy. As we all know, it's straightforward. You know a person is alive or not. It's unambiguous. Quality of life, as we all know, is complex and multidimensional, and measurement is not as straightforward. The type of cost effectiveness analysis that includes QALY as the unit of effect is known as cost utility analysis. Although this distinction is not consistently used in literature, so you will come across studies where in effect they're doing a cost utility analysis, but it's called a cost effectiveness analysis. Now, how do we estimate the quality of life in QALY equation? Here's where PROMs come into picture. So we all know there are several indicators for improvement in health. For today's discussion, let's focus on quality of life. Quality of life, as we know, can be measured by patient-reported outcome measures. For PROM to be used in cost utility analysis, it should meet two basic requirements. And these requirements should be very familiar to you if you've been a member of the Proof Summer series. It should, first of all, absolutely measure what matters to patients. And secondly, it should have established measurement properties. However, when PROMs are used in cost utility analyses, they're subject to additional requirements. First, PROMs used in cost utility analysis should be able to summarize the change in quality of life in terms of a single number. And so this is important because when you think about it, when we are comparing interventions across conditions and specialties for resource allocations, decision makers are only interested in knowing one thing. And that thing is that, did the intervention make the health better, worse, or was it not affected at all? They're not very much interested into the minor details or the attributes that change, but if there was a change and the direction of it. Further, for use in cost utility analysis, we need to be able to compare the quality of life impact or change in terms of value. So in short, PROMs used in cost utility analysis need to extend the concept of what is important to how much important it is. They not only need to describe the health state of an individual, they also need to tell us how much value an individual places on that particular health state. Now you may ask, why do we care about values in cost utility analyses? Now the concept of value is important because we all agree healthcare resources are finite and potential uses of those resources are infinite. How much value we placed on an outcome determines two things. First, how much we are willing to pay for it. And second, what are we willing to give up for it? Commonly known as opportunity cost. Now let's think about our everyday life. The concept of value, even though we don't conceptualize it in that fashion, is not new to us. Even in our everyday life, we place different values on attributes of a product, good, or a decision under consideration. So we make decisions, we make trade-offs from the moment we wake up and decide to hit snooze versus going for a run. We decide how do we get to work, what to eat, big purchases of life, like what car to buy, what neighborhood to live in, and even attending the Proof series today. We have all decided that being here today is a better investment or, bigger bang for time, let's say, than doing something else. And thank you for that. Patients similarly face these choices in almost every encounter with a healthcare professional. So let's say an elderly male with bladder cancer, when provided with two surgical options that are shown to have slight difference in survival gain, but substantial difference in terms of urinary incontinence or urgency, may consider how active they are and how frequently they find themselves without access to a restroom. So for example, a patient who values staying physically active by means of running may choose the intervention where mortality may be slightly higher, but have reduced incidence of urgency in comparison to a patient who stays active by means of exercising at home, which means has easy access to a restroom. Similarly, the decision of a woman to undergo reconstruction following mastectomy may be determined by how much value she places on satisfaction with appearance, feeling confident at work, in personal life, her relationships, recovery post-surgery, which may have an impact on how she cares for a loved one, and even culture. So what we've learned up until today is that what matters, so these attributes can be obtained by means of a well-designed qualitative study where we gather input from a heterogeneous sample of women to understand what matters. But how then do we obtain values? Now, we know from what we've learned so far is that values require trade-offs, and they can be elicited by two main methods. You can ask someone, hey, how much are you willing to pay for being in a particular health state? So you're essentially comparing the outcome or converting the outcomes in terms of money. And these are called as willingness to pay analysis studies. In healthcare, there are implications because you really want equitable access to healthcare, so you do not want to convert outcomes into money. The another way that you can assess or elicit values is by assessing how much satisfaction or really like how much happiness or utilities someone obtains from being in a health state. So what is health utility? Health utility basically means the strength of value or preferences. So how strong your preferences are for a particular health attribute. They're typically measured on a scale anchored at 0 to 1. Negative values are also possible that represent states worse than that. So sometimes cancer patients, for example, would experience states that they consider worse than that, and they will have values from -1 to 0. Health utility is measured on an interval scale. So essentially what we are doing by means of health utilities is we're quantifying quality of life outcomes in a single number format. So that begs the question, then how do we estimate health utilities? There are quite a few methods by which health utilities can be obtained, but the most frequently used method, the one that is recommended by several health technology assessment agencies, the one that's inexpensive and has the least amount of cognitive burden on the individual completing it, is preference-based measures. Now, preference-based measures differ from PROMs in two main ways and have two main components. They describe health gain in terms of quality of life and are multidimensional, just like PROMs. But unlike PROMs, the number of items per dimension is limited. Each quality of life dimension is measured by 1 or 2 items only, and here's why. So let's go back to the example of a woman deciding if she should undergo breast reconstruction or not. If she considers the multiple sort of aspects that fall under each of the attributes, so for example, satisfaction with appearance, how she looks clothed versus unclothed, how the bras fit, do the breasts match, if she considers psychological well-being, she's looking at, am I feeling confident, how does it impact me feeling attractive, feeling self-conscious about appearance, so, and physical well-being, sexual well-being, social well-being. So all of these attributes, when they come into a single decision, they can become very, very difficult to trade off the value. Now, while we're doing all this, there's no explicit way of doing it apart from choosing what's most important out of each dimension and then using those dimensions in a health utility measure. So therefore, because you do that, because you limit the number of items that can be used per dimension, preference-based measures tend to be short. So typically they'll have 7 plus or minus 2 items. This type of PROM sometimes are also known as indexes, and they can be generic or condition specific. In addition to the descriptive system, preference-based measures also include a preference-based value set. This means for each health state that is defined by the preference-based measure, a value is assigned. And this value can be based on the values of general population or patients. So before we delve into this further, let's quickly take a look at the terminology used in health preference literature with the example of EQ5D. So EQ5D that you see on the right-hand side here is the most common generic preference-based measure developed by the Eurocall group. The 5 in EQ5D stands for the 5 attributes or dimensions of quality of life that are measured by EQ5D. So mobility, self-care, usual activities, pain or discomfort, anxiety or depression. The version that I've shown you here is known as the 3L version, which essentially means it has 3 response levels: no problem, some problem, and confined to bed for mobility or extreme problems. To define health state, having no problem in a dimension is assigned a value of 1. 2 means some problem, and 3 means extreme problem. So a health state of an individual completing EQ5D will look something like this: 1, 1, 1. So 5 ones meaning this individual has no problems in walking about, no problems with self-care, no problems with performing usual activities, no pain or discomfort, not anxious, and so on and so forth. Doing this, the number of health states then that are defined by descriptive system of EQ5D, the 3-level version, is 243 health states. And there's another 5L version where there are, instead of 3 response levels, 5 response levels. And obviously that defines more health states. Here's what the descriptive system of some of the other generic preference-based measures commonly used in literature looks like. So as you can see, the constructs of health-related quality of life that are included are different in each of these measures. So they measure different attributes, they have different number of dimensions, they have different response levels. And obviously that results in different number of health states defined by the preference-based measure. Now let's look at the second component of preference-based measure, which is the preference-based value set of a PBM. Now this can be understood by breaking this down into what is a value set, how are values elicited, and who is valuing the health state. So what is a preference-based value set? So as I mentioned previously, value set is a scoring algorithm that is developed by eliciting values. So you look at all the health states that are described by preference-based measure. You used direct valuation techniques that I'll describe in a minute to elicit values for selected health states. And then you use the values of the selected health states and estimate the values for all the health states that are described by the preference-based measure. So the most commonly used or the established ways of eliciting preferences or utilities are rating scale or a visual analog scale, standard gamble, and time trade-off. So what is rating scale? Rating scale is essentially a visual analog scale with well-defined endpoints, where respondents can indicate how they're feeling, their judgment, or values. The distance between the intervals on VAS should reflect a person's understanding of the difference between the concept measured. So in a sense, they have interval level properties. So as we know, interval level properties mean change from 3 to 5 is same as change from 5 to 7. Now, these rating scales or visual analog scale based methods are the easiest of all methods, but also the least preferred to elicit health utilities. And if you think about it, it's because they're missing the key aspect of health utility estimation. There are no trade-offs involved. Participant is not choosing between different health states. They're simply telling us how much they value one health state. So that conceptually doesn't sit well with health utility estimations. Measures such as EQ5D and Health Utility Index, or HUI, use rating scales to come up with the value set. Another established method is standard gamble. In standard gamble, what you do is you essentially give respondent a choice between a certain intermediate outcome and the uncertainty of a gamble between an outcome that is considered better than the intermediate outcome or worse than the intermediate outcome. So for example, if somebody is seeking surgery for vision-related problems, they can either for sure not have treatment. So this would be their certain outcome, and they would For example, live with partial or total blindness in one eye or both eyes for X amount of years, and X meaning their remaining life years. Or they can undergo treatment and have a gamble where they can either have success, which would mean perfect vision for the remaining life years with a probability of P, or there's a risk of failure, which is worse than the certain outcome. And in this case, let's consider it's immediate death. The value of the P, so the probability of the success outcome, is varied until the individual is indifferent between the two outcomes. And this is repeated for all intermediate outcomes. This approach is used by SF60 and Huey. Standard gamble is considered gold standard. And if you understand why rating scale is not, you'll see why this is perfect, because it has an element of choice and it has the element of uncertainty. Most of the healthcare decisions are made under the circumstances of uncertainty. However, this is not how we think in everyday life. When we are assessing the value of decisions, we rarely think about probabilities. So it can be a very, very challenging way to elicit utilities. It's cognitively demanding, and that reduces the validity of values that you get, and also limits the sample that you can use for this exercise. An alternate method known as time trade-off was proposed to overcome these problems with explaining probabilities. So essentially it overlaps with standard gamble in that you're still offering an individual a choice, but here you're choosing two alternatives with certain outcome rather than uncertain outcomes. In time trade-off, you offer paired comparisons. So alternative one typically would look like living in T, let's say years, in an intermediate health state, which is less than full health. Remember, like 0 is death, 1 is full health, or choosing to live less number of years, but in perfect health. And then you vary the number of years until the individual is indifferent. And the score that is given to full health state is then X divided by T. This method is used by EQ5D. So now that we know, so just to summarize, preference-based measures then have a descriptive component, a valuation component, and the value set component is elicited by primary 3 methods. So they are rating scale, standard gamble, or time trade-off. Now that makes the question, then who is valuing these health states that are defined by the preference-based measure? Now you can either have patients or general population. The argument on the patient side is that they are the ones who are experiencing the healthcare, the health state, and are the ones that are most impacted by the intervention or the lack thereof. So they should be the one are valuing health states. However, as Dr. Pusick mentioned in the introduction, general public is usually the one paying for healthcare. So many believe they should be the ones deciding how much or what is the value of a particular health state. As such, because of this type of thinking, using general public is recommended by many health technology agents, health technology assessment agencies, and therefore it is the approach that is most commonly used. For measures such as EQ5D, SF60 that are more commonly used, value sets have been established at the level of population for many countries. So for example, if I was collecting EQ5D data in a sample of Canadians undergoing an intervention, I would look up Canadian value set or the scoring algorithm for Canadians on the YourCall website. If one exists, you'll be able to look up the scoring algorithm or the utility for all health states, and it would look something like this. Using these values, then you can estimate the utility value for an individual who reports, let's say, no problems with healthcare. So their value would be 1, and then you would look at the key and come up with if somebody reported some problems in walking about, but no problems anywhere else, their utility would go down to 0.84. And then as we go and do this exercise, we'll see as an individual experiences more problems or severe problems, the utility will continue to decline. So we know that the whole purpose of estimating utilities was to then estimate QALYs, which will then feed into the cost utility analysis. So this is how QALYs are calculated. We have a length of life, which we estimate by survival or the remaining life years. You have utility values from 0 to 1, 0 with death and 1 being perfect health. So let's say there's an intervention that increases quality of life by 10 years and has utility of 0.5, the QALYs would be simply multiplying length of life by the by the utility value. So 5 QALYs. When you're comparing interventions, so let's say you want to see if QALYs are gained or lost. Let's take the example of conservative management versus bariatric surgery here. If conservative management is shown to increase quality of life by 4 years, and the utility for those years is 0.3, the QALYs would be 1.2, whereas bariatric surgery may show that it increases length of life by 7, and utility by 0.7, so the QALYs would be 4.9. This would result in a gain of 3.7 QALYs by undergoing bariatric surgery compared to somebody who was not. So then what do you do for cost? How do you estimate if it's cost effective or not? You simply divide the difference in cost with the difference in QALY. So just randomly speaking, let's say the difference in cost between bariatric surgery and conservative management was $300,000. Your cost per QALY would come to $81,000 roughly per QALY. So for 1 unit increase in QALY, you're paying $81,000. How does this all fit in with the assessment of if intervention should be funded or not? Well, what you do is, this is known as base case analysis in cost effectiveness interventions. You run several simulations, and by using that, you're able to come up with a variety of situations and estimate per QALY value of all of those situations for the exact same scenario. And then you plot where your value lies on what is known as an incremental cost effectiveness ratio plane. So when you plot interventions that are on an effectiveness on x-axis, so more effective to less effective, and cost on y-axis, you basically end up with something that looks like this. Interventions that fall here are a win-win scenario. They're more effective, they're less costly. Absolutely, everybody should be doing it. Whereas interventions that fall on this quadrant, in this quadrant, are lose-lose, meaning they're more costly, less effective, nobody should be doing it. These are known as intervention dominated because essentially there's no decision-making involved. The choice is clear. However, when you get into more costly, more effective, or less effective, less costly, this is where decision-making occurs. For interventions that are less costly and less effective, typically those judgments are left up to clinicians or healthcare providers. Interventions that are more costly, more effective, are determined by what is known as a threshold, an ICER threshold. Threshold meaning how much the health organization has decided that they are willing to pay for per QALY gain. So for example, let's say this was the ICER value and they have changed they are different for different health systems. They've changed over the years. So for example, about a decade or so ago, in the United States, the ICER threshold was $50,000 per QALY. So if an intervention was in this quadrant and was cheaper than $50,000 per QALY, it would get a pass without arguments. If it was over $50,000 per QALY, then it would typically not be approved. And that has changed, and now interventions around $100,000 to $120,000 per QALY are considered cost effective. So then this line represents the threshold. So for that health system, and then you decide where majority of the data falls. And most cost effectiveness analysis would look something like this. So if you're reviewing a paper on cost effectiveness, you'll see the quadrants and you'll see how interventions are falling and where interventions are falling on which quadrant. So now that we know how cost utility analyses can be conducted with patient preference data, some of the key things to consider are choice of preference-based measures. So Danny clearly demonstrated with the help of examples in the last week how there is no replacement for thoughtfully choosing a PROM that is fit for purpose. Similarly, when designing a cost utility analysis, we need to carefully consider what PROM to use. This choice is often dictated by the purpose of cost utility analysis. So for example, if your purpose of doing this exercise is to submit the data to a health technology assessment agency for resource allocation decision, the choice of PROMs should be dictated by the health technology agency requirements. Most agencies require EQ5D. Still, there are other important things to note. We saw previously that not all preference-based measures measure same attributes, have similar response levels, or even use same methods to estimate value sets. Research has also shown that generic preference-based measures suffer from ceiling effects. So for example, for vision or skin-related problems, improvement in health is not adequately captured. And this is risky because then you end up the risk of rejecting a worthy intervention. EQ5D has tried to respond to these criticisms by increasing the number of levels. However, there is no evidence yet to say for sure if moving from 3 response levels to 5 response levels helped with the ceiling effect. Lastly, not all condition-specific generic preference-based measures are responsive to condition-specific concerns or condition-specific patient-reported outcomes, and therefore you need to come up with either condition-specific preference-based measures. Other strategies that have been used are mapping patient-reported outcome measures to preference-based measures or bolt-on items for generic preference-based measures. I will elaborate this further and recap what we've learned with an example of the breast-QU. So breast-QU is a condition-specific preference-based measure developed for use in women diagnosed with breast cancer. So first, why breast-Q in its current form cannot be used? So firstly, breast-Q was developed for breast cancer surgery only. And while it does a fantastic job of describing the quality of life concerns that are important to women, it does not provide any indication of how women value those aspects of life. And as such, no preference-based value set has been established. So what we did was we started by reviewing the landscape of published utilities in breast cancer. We conducted a systematic review, identified 79 studies, and noted that EQ5D was the most commonly used preference-based measure in breast cancer. No breast cancer-specific preference-based measure was identified. This was a gap, and so we decided to fill it. And here's why this gap was necessary to fill. If we look at the descriptive systems of the most commonly used preference-based measures, you can see that they do not capture the concerns that are important to women. Appearance, body image-related issues, be it overall or chest-specific, physical symptoms such as fatigue, nausea, vomiting, peripheral neuropathy that are known to be important to women with breast cancer are not captured here. So why does it matter? So apart from the content validity, this is what can happen. So let's say you're comparing the exact 2 breast reconstruction techniques. Using different PROMs or preference-based measures, you can come up with different qualities. So let's say using preference-based measure 1 gives you a quality of 0.8 and a cost per quality of $125,000. Same scenario, same treatments, a different preference-based measure can result in different quality estimates and therefore different ICER estimates, and similarly. So this can have a significant impact on resource allocation decisions. So we set out to develop breast utility module. There were some approaches that we considered. Now we could have used the approaches that are used in literature. We could have used existing data sets to reduce the item list in breast-Q using modeling techniques to come up with a short list of items and validate it in same or different samples. Now, this would not have worked because our goal was to come up with a utility measure for breast cancer, and breast-Q at that time was only developed for women undergoing breast cancer surgery. So that idea was quickly abandoned. The second option was developing a scoring algorithm to map breast-Q to existing preference-based measures. Again, breast-Q was developed for breast cancer surgery, and crosswalking an instrument that is conceptually different than the measure that it is being mapped to felt like trying to fit the wrong key into the lock. Finally, our third option was developing bolt-on items for existing generic preference-based measures. This method of developing bolt-ons is fairly new, and only a handful of studies have used to date. So there's no evidence or limited literature on how to best select the item, what is the optimal number of items that can be selected as bolt-on, and how the instrument is ultimately used in cost utility analysis. So instead, we went to patients. We adopted a bottoms-up approach, and we conducted a mixed methods, multi-phased, multi-center study where we asked patients what aspects of quality of life were important to them. We also asked women to rank the importance of breast Q items so as to get a better sense of which items they were valuing more. Expert feedback was sought throughout the development of the descriptive system, and content validity of the breast Q utility module was assessed in patients. If you're interested in learning more about our protocol, the protocol paper is now published in BMJ Open, so it's an open access journal. And right now what we are doing is we're analyzing data from the field test of the descriptive system, following which we'll move on to develop the preference-based value set for the breast Q utility module. Once the breast Q utility module is developed, we hope that it'll be used in research to compare health and treatment effects across different studies within the patient group and capture the additional benefits of an intervention that are not captured by generic preference-based measures. Finally, we hope that it'll be used in health technology assessments to conduct sensitivity analysis of the cost utility analysis to show the impact of using a generic versus condition-specific preference-based measure on the incremental cost-effectiveness ratio. Finally, to conclude, the aim of maximizing efficiency of healthcare system lies in producing the highest number of QALYs that we've seen. More QALYs, less cost, better the intervention. However, it wouldn't be fair today to let you go without reviewing some of the limitations of QALY. So in QALY, an implicit assumption is that all QALYs are of equal social value, irrespective of who gains them. So this is famously coded as QALY is a QALY is a QALY, which implies that QALY gained and lost is blind to health conditions or personal characteristics, including age, gender, severity of disease, level of deprivation, social role of individual, area of residence, and other individual characteristics. Taxpayers and even policymakers are not always concerned with getting the biggest bang for buck. Even though delivering interventions in hard-to-service areas, areas with low socioeconomic groups may be less cost-effective, ultimately it results in a more equitable society. QALY sort of overlooks that. Lastly, QALYs, as we saw, it is recommended that who should value health is general population, and that has its own implications. Member of general public may not know how breast cancer or prostate cancer impacts life of an individual. So are they really the best people for valuing the health states? That is a debate that has been going on in the health economics world for many, many decades, and it's ongoing. So some of the key messages then from today's session. The use of PROMs in cost effectiveness or cost utility analysis requires an extension of what matters to how much it matters or how much the outcome matters. Health utilities anchored at 0 to 1 are used to gain an assessment of the value of an intervention, and negative values are possible. Preference-based measures are commonly used to elicit health utilities. They tend to be short, consist of descriptive system in addition to preference-based value set, and condition-specific preference-based measures, as we saw, are crucial to use in cost utility analyses, especially when generic preference-based measures do not capture the impact of condition or intervention. Lastly, it's important to consider that utilities or QALYs make up only 50% of the cost utility analyses. Rigorous costing is equally important. And with that, thank you for your attention today.
Thanks, Manraj. That was fantastic. You take a very difficult topic, I think, and really laid it out. And that, so in 45 minutes to cover all of that, that was no small feat. So thank you for that. I'm sure people have lots of questions. And it's one of those things like, where do you jump in? But maybe I'll, one thing I just like to highlight again is one of your last points was the importance of sort of when we think about the implications of utility measurement, or it's similar to the idea we talked about with PROMs, that if you pick a wrong, that to Danny's talk, you pick the wrong PROM, the implications are that your study may show no difference when there really was a difference, but you just weren't asking the right questions. And I think to your point about using the right utility measure, if say body image is important, but you're using a utility measure, a preference-based measure that doesn't assess body image. I mean, we're just building on the breast and thing, but there's lots of other, think of other things that for those that are listening, about sort of other things that in the clinical realms, but you could end up not seeing a difference, or not seeing that it's cost effective, and that has happened. I know in the UK there was a lot of work around PROMs and using, say, EQ5D, looking at major hip and knee replacements and not finding differences, and of course everything, no data point is taken completely in isolation. But when the story points in the direction that, say, if a generic PROM was used to assess the impact of an intervention and it doesn't show a difference, that's that has implications as to whether that procedure will be reimbursed in the future. And so for us, particularly, PROVE is a lot about surgery and surgical intervention. So I think utility measurement and having a really good understanding of utility measurement and how that fits into patient-reported outcome measurement and that whole is really important. I think you did a great job pointing that out. I know we have one question here. Danny, do you want to read this one for Manraj?
Yeah, sure. So this question is by Toby Elijah from McMaster. He says, thank you for the great presentation. So that's the first compliment of the day. You mentioned that a limitation of CEA is that you cannot compare a life year gained across different years, 20-year-old to a 70-year-old. Does the QALY suffer from this limitation as well? In other words, can you compare a QALY gained or lost across different age ranges?
Right. And so I think the slide that I had, the last slide, sort of alluded to this factor. So QALY also suffers from those limitations. A QALY gained is a QALY gained. It doesn't matter who gains it. So then it's up to the society or the decision maker to say, well, quality of life. So QALY gained for a 10-year-old, is it more relevant in terms of investment to QALY gains by a 70-year-old. But again, you don't want to be basing those kind of decisions on the health of an individual or the contribution that they're going to make in a society. But it is a valid argument. So QALY does suffer from efficiency versus equity sort of debate. Another important consideration for QALY is if somebody has better access to healthcare, is in a better health to start with, they're going to have more numbers or more life years gained, right? So the overall survival rate is going to be better for that individual compared to an individual who already lives in like poor socioeconomic status, poor access to healthcare. Their survival gain is not going to be as much. So when that all comes together, because QALYs are aggregated when you are making a judgment on treatment is cost effective or not, high QALY gainers are going to nullify low QALY gainers, and that's going to nullify the impact. So as a decision maker, then it's up to you to sort of assess where value is. And I think the next seminar in the summer school series on value-based healthcare will sort of open our eyes a little bit more to this issue on what value is at the level of an individual. Cost effectiveness analysis deals with what value is at the level of health system. And value-based healthcare, as I look at it, is sort of like a cousin, younger cousin of cost effectiveness analysis that deals with individuals. So I don't know, Toby, if I answered your question, but feel free to ask a follow-up question or follow up with me after the talk.
Yeah, I think Toby also...
Actually, Toby did ask a follow-up question.
Yeah, and I actually appreciate, I think it's a good follow-up question, actually. You go ahead, Danny, you've seen that, because I think I'll let you finish with Toby's question because it gets the heart of it. That you're really appreciating something important there, Toby, about sort of the what I would consider one of the limitations of utility measurement. Go ahead, Danny.
Yeah, so Toby asked, you mentioned that the industry standard, the recommendation from HTA agency was to develop utility values from the values of the general public or taxpayers. So he says, I was wondering, why not take the approach in the development of the rescue utility measure?
Yeah, so that is a great question, Toby, and that is, I think, where most of us get confused. So we will take that approach for breast Q utility measure. So what you're talking about here, or alluding to based on your question, is the preference-based value set. We went to patients for developing the descriptive system. So, asking what matters. So coming up with the descriptive system was all in for by the patients. Whereas when we move on to the next stage, once it's field tested, we refine the items, and then we move on to developing value sets. We will be looking at it as more of an academic exercise. So we will elicit preferences or value sets from both breast cancer patients and general population to see if there is a difference. And we'll also be looking at sort of generating the type of evidence that most health technology agencies look for. A key consideration here in terms of whether general population should be used or patients should be used is also that in member of general population who has had some experience of the condition by means of either experiencing themselves or by means of caregiving may give you different values, right? So if I know someone, or if I have cared for someone with breast cancer, even though I'm a member of general public, my values may be different because I've seen the impact on an individual. Whereas somebody who has never had any experience may give you different values. So there are quite a few nuances to consider in terms of how do we define general population and how the composition of general population is swaying the values. I hope I didn't confuse you even.
I think that's good.
Yeah,
I think that is part of breast QU. We are going to make that comparison and understand it because I think some of this comes from the health economists working in countries where healthcare was a national resource, and so it really is essentially the taxpayer, as I said right at the beginning, is the taxpayer making decisions about the value of things. But there is an inherent limitation to people being able to really understand the lived experience of a condition based on a scenario. So I think that's where, and there's lots of different examples of that where people would say, I'd do anything to avoid living in a wheelchair. I'd rather that than actually someone who's actually lives in a wheelchair and has a full life and a family and such would say, that I'm fine. They would value it very differently. So I think that's why and probably my bias would be towards thinking that we should be actually thinking about the perspective of patients who've had that condition to get the more accurate understanding.
Mm-hmm. And I think what is cool about this sort of area of research is that it's still evolving and there are so many unknowns. So, whether QALY is the best way to do this, because there are alternatives that have been proposed. If patients should be used versus general population, it's such a good academic exercise. So yeah, as Dr. Pusick mentioned, we'll be exploring both of those to not only contribute to the evaluation, the economic evaluation of breast cancer interventions, but also to contribute to the field of health preference research in general and advance the science in the measurement of health utilities.
Yeah, I think when you're saying academic exercise, it sounds like it's not important, but it's what you're saying is to try and advance the field. And what I think is particularly cool is us bringing the world of PROMs, where we really focus on the lived experience of the patient, to the world of utility measurement, which they have as well. But I do feel that there's been there's much that we can bring closer together because they actually have existed side by side for a long time and not had as much interaction as you might think. And so I actually think that, so from a methodologic perspective, I think that this kind of, people basically are either your utility people or your PROM people, in the sense that, and I think actually the intermingling of the sciences in the same way we've seen that in terms of psychometrics and education, psychology, I think has been to the betterment of it. And so I agree. I think it's a really cool area, and there's a lot of things that are being worked out still, and yet never has it been more important for us to understand and I appreciate also saying it's not just about saving money. As you say, there's like as a surgeon, I save money by not going to the operating room. It's about using our resources in a way that benefits patients most. And that may mean that there are some things that we do that don't actually have the patient benefit that we thought they did. And we might not want to do those things, but then there are other things that we may be doing, the other interventions that have greater value than we realize or have previously realized that we should be putting greater resources towards.
Mm-hmm.
Yeah, great. Manraj, really great talk. I think that, that's it for questions. I would, thanks everybody for joining us. And Manraj, really, that was fantastic. I think there, if others have other questions after the, I'm sure Manraj will be open to emails as well. So Joanna can pass them along. I can't believe it, but next week is our last session. I refuse to say it's the end of the summer because it's been such a funny summer, and I'm hoping for an Indian summer where it just goes on and on through September. But it is our last session for the summer series, and I'm very pleased that Tom Feely will be with us speaking. He and I will speak together about value-based healthcare. And Manraj, I thought this was a great lead into that because I'm sure Tom is happy to hear that it's the younger cousin of utility measurement, cost utility analysis is value-based healthcare. But there absolutely is they're related in the set of, I said, they distinctly different things, but related. And I think that's, again, to gain an appreciation for how this all fits together is what we're hoping for to bring to you this summer through the summer school. And so I'm very pleased that Tom and I will be speaking together about that and kind of a wrap up of the summer overall. So so I hope you can join us. And again, Manraj, thank you. And Danny, thank you as well. We'll see everybody next week.
See you.
See you next week. Bye-bye.
Bye.